My name is Uma Thanarajasingam. I am one of the chief internal medicine residents at the Mayo Clinic in Rochester, Minnesota. The paper we'll be discussing today is entitled Service Census Caps and Unit-Based Admissions, Resident Workload, Conference Attendance, Duty Hour Compliance, and Patient Safety. The article will be published in an upcoming issue of the Mayo Clinic Proceedings. Of late, much attention has focused on the reduction in resident duty hours in hopes of decreasing resident fatigue and enhancing patient safety. However, far less consideration has been given to determining the optimal workload for residents to achieve the best learning and provide safe patient care. Reductions in resident workload have been associated with increased resident satisfaction, improved quality of resident documentation, and also increased time for teaching in the hospital setting. However, several factors continue to contribute to high resident workload. One example is the inpatient volume, or the census that residents see or a resident team see while in the hospital. Another example is work efficiency, with one specific example being the time a resident spends traveling in between hospital services caring for their patients who are geographically dispersed. So by geographically dispersed, I just mean patients that are located on different hospital wards that can be separated by often long distances within the same hospital. In our study, we sought to decrease resident workload and enhance resident education. And in order to do that, we implemented a service census cap, or a team cap, of 14 patients on each of the internal medicine resident hospital services at St. Mary's Hospital in Rochester, Minnesota. St. Mary's Hospital is part of the Mayo Clinic system. And in addition, in order to increase work efficiency, we also developed a unit-based admissions process whereby patients and their multidisciplinary care teams were geographically located or consolidated in the same hospital unit. We then went on to try to study the impact of these two interventions on several parameters. These included residents' perception of their workload and education, residents' educational conference attendance and duty hour compliance, as well as several patient safety measures and indicators. All residents on the 6 internal medicine resident teaching services and all patient admissions to those services 1 year before and 1 year after the interventions were included in our study. In order to determine resident satisfaction with their workload and education, we administered an electronic survey at the end of each ward rotation. Resident conference attendance was recorded via an electronic card swipe system, and resident duty hour compliance was measured by resident self-report using an electronic survey, again administered at the end of each ward rotation. Patient safety indicators were determined for all patients in our study, and these included but weren't limited to rapid response team events, cardiopulmonary resuscitation events, transfers of patients from the medical floor to the intensive care unit, and 30-day readmissions. And by 30-day readmissions, I mean those patients, those number of patients discharged from a single hospital service that then required readmission to that same hospital service within 30 days of discharge. We first demonstrated the effectiveness of our interventions, and what we found was that in the post-intervention period, none of these 6 resident hospital services violated the cap of 14 patients per service. In addition, we also saw that unit-based admissions occurred over 90% of the time in the post-intervention period. And one interesting finding was that the total number of patients, or the average number of patients per team, did not decrease significantly in the post-intervention period. Rather, the variation in the number of patients per team decreased in the post-intervention period. And this was important to us because we were concerned that by implementing a service census cap, we would decrease the total patient experience for our residents. And in fact, this was not the case. The system was simply more efficient, and the residents were still seeing the same average number of patients. Post-intervention, we found that the residents' perception of the appropriateness of their workload improved significantly. In addition, despite the implementation of a service census cap, residents' perception of the appropriateness of the range of pathologies they managed remained very highly rated in the post-intervention period. In addition, we found that residents attended significantly more educational conferences in the post-intervention period. In terms of duty hour violations remained exceedingly low in both the pre- and the post-intervention period. Nevertheless, we were still able to see that for certain duty hour requirements, there was a statistically significant decrease in the number of violations in the post-intervention period. For example, for the requirement to have 10 hours off between duty periods. In terms of patient safety indicators, we found that the number of 30-day readmissions significantly decreased in the post-intervention period. However, when we adjusted for expected mortality and expected length of stay, this number did not reach statistical significance in the strictest sense. However, the trend was clearly one towards a decrease in those 30-day readmissions. For all patient safety indicators, we did not see any difference in the pre- and post-intervention period. Overall, the results of our study indicate that service census caps and unit-based admissions do result in decreased resident workload, enhanced resident education and resident conference attendance, decreased duty hour compliance, all while maintaining a high level of patient safety. This study does have implications for clinical practice and patient care. It is imperative that residency programs continue to find ways to manage resident workload while optimizing resident education and maintaining patient safety, as well as adhering to the current duty hour standards. One of the major strengths of our study is that we demonstrate two interventions that decrease resident workload and enhance resident education. And this is in contrast to other studies which have demonstrated a decrease in the clinical experience of residents with more restrictive duty hours. Another strength of the study is that it demonstrates that unit-based admissions and service census caps do not decrease patient safety and in fact may have a trend towards enhancing patient safety. The next steps for this line of research are to try to implement this model at other institutions in order to determine feasibility and reproducibility. And of course, we'd like to continue to look into sources of resident inefficiency, for example, in documentation or in discharge planning, in hopes of improving resident efficiency. And this is especially crucial in this era of further duty hour reform. The takeaway point from our article is that census caps and unit-based admissions represent a feasible model for decreasing resident workload, enhancing resident education, and improving duty hour compliance without sacrificing resident patient experience, and all while maintaining a high standard of patient safety. We hope that this is a model for other residency programs to consider as they seek to educate their residents while complying with the current duty hour standards.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.